in New England Journal of Medicine. New England Journal of Medicine is 1872, if I'm right. It's a very, very old journal, very prestigious. And they have these case discussions, which they used to call them Cabot cases. And these cases are done up very well. And whether you are undergraduate, postgraduate, or no graduate, this is one of the best learning exercises. I remember when we joined medical school, I joined in 71, so that was in AIMS, and Central News Agency used to be just next to you in CP. They used to take this subscription for New England Journal of Medicine. It used to be a big journal with ads those days. And till today, you can go through those cases alone, even if you don't read. There's so much. And these days, they've made it real skill oriented, because there are these videos that are available, there are audios that are available, and very good stuff. It has become more clinical now. So I think it was good on the part of Nilayan to say that I would present. And then I think he worked through the day and night, and he said, I'll not present one, but I'll like to present two and maybe sum it up later. And I think Nilayan will do a great job, I'm sure. And all of you, please listen to him. Ask him questions on the chat box or hands, if you, whichever way is possible. And let him, you support him and you learn from what he is trying to convey. So here your time starts now, Nilayan. Go
yes,
ahead.
Sir. So I'll start the presentation, sir. So we have two cases lined up. I hope everyone can see. Yes, okay. So the first case is in the form of aliquots. Basically, wait, the slide hasn't moved, has it? Oh, I guess, yes, the slide has just moved. Okay, so the first case is presented in the form of aliquot. So I have broken a proper case into 5 parts, and it is in the form, for example, the first aliquot will give us chief complaints. The second aliquot will give us the rest of history. The third aliquot will give us examination. The fourth aliquot will be investigations. We will also like to discuss investigations in this case. In this case, it's a very interesting case, sir. And the final aliquot will give us a diagnosis. And the second case I'll present is a prototypical exam case that is taken in the proper format. So that's we also get a practice of how to present in the examination. And I've written I've tried to incorporate as many things as I could in the slides, sir, but I have left out few things which I'll try to say it aloud. And the last line says these 4-5 things are the exam cases from the topic of CVS. So I'll start my presentation now. Okay, aliquot number 1. A 59-year-old man presented to us with a 3-day history of vomiting, diaphoresis with altered mental status. So I would like to stop here and would encourage everyone to give us their thoughts in the chat or wherever they want to.
This could be a case of maybe some hepatic problem, because hepatic encephalopathy could be it, because it's vomiting and altered mental status.
Possible, agreed.
Hey, anybody else? The rest can put on the chat. So we have somebody else also. Shivaha is there, Nikita is there, Pragya is there, Parinita is there, and Nilayan is there.
Yeah. So, sir, in the chat, Ria says diabetic ketoacidosis. Ria says some poisoning. Sarthak has said viral encephalitis. And Pratik has said it's too early to say anything. And Pari has said it looks like something to do with brain. I'm just reading out the chat, sir.
No, Nilayan, tell me something. Why am I not seeing these on the chat? I'm seeing my own thing on the chat, nothing like what you're reading out.
Okay, sir. Okay, sir. So I'll guide you through it. Sir, so
Yeah,
I
yeah,
think you can.
it is under the questions.
Yes, sir. Another question, sir. There is a small box with an arrow on the right hand side. If you can see the
Yeah,
question, sir. So you
that
have
is
to click
okay.
it, sir.
Yeah.
And sir, scroll down, scroll down, scroll down.
No, no. What I was saying was all these things are being written down under questions, not under chat. So there are two separate heads. That
Yes,
is
sir. Yes, sir.
okay.
Yes, sir.
That
Yes, sir.
is okay. Okay, so we have a lot of them. You said diabetic and viral encephalitis and poisoning. And isn't it too early to say to draw a conclusion like this? Isn't it too early to draw a conclusion like this? But how do you react to that, Nilan? Just on one line, you want to draw a conclusion? Is that right?
Not exactly, sir. Not conclusion, sir. I just wanted to discuss all the possible, all the possibilities we can have in this patient, sir. At least have a basic idea on what this patient could have possibly.
Okay, so let's go back to the basic of the basics. So whenever you are in the ward, clinic, home, or wherever you come across a clinical scenario, when you take a clinical history, apart from the details that you take relating to your subject, the first part of the history is what is called the presenting complaints. Remember that the first part is presenting complaints, one or two or maybe maximum three. So here the presenting complaint was vomiting, diaphoresis, confusion, nothing more than that. The second part which will follow will be history of presenting illness. Remember, there is a difference between the two. First, this one is presenting complaint, what he comes with, and then is a history of presenting illness. The idea is presenting complaint is something which concerns the patient very much. They are not interested, my headache is because of the tumor in the head, or it is because of stress, or it is because of stomach. So for them, management of the presenting complaints is of utmost importance. For the doctor, the primary objective of the presenting complaints, history of presenting illness, past illness, and the whole rigmarole that we'll see Nilan going through today would be to arrive at a diagnosis. That is your prime, because unless you have a diagnosis, there is no treatment, no prognosis, nothing can be done. And for arriving at a diagnosis, you must start thinking from the very first sentence, even before non-verbal communication, even on the non-verbal communication, you must start thinking what could be the diagnosis. And diagnosis, I'm meaning a complete diagnosis, very large domain. So when you speak of vomiting, diaphoresis, and confusion, it's very often that vomiting, it comes, maybe it is stomach or liver. But as we have heard, there is encephalitis, there is tumor, there is diabetic ketoacidosis. There are many things that can give rise to this. And remember, this triad of vomiting, diaphoresis, and confusion also goes with reactive autonomic changes that you can see, let's say, in hypoglycemia and diabetes, not only ketoacidosis, hypoglycemia also. So it is very non-specific. Maybe too many systems are involved. As somebody said, looks like we can't pinpoint, and you also said we cannot. But we must keep our domain open, and it is unlikely that we would think of, let's say, can you have a renal cause for this, Nilan? We are talking about cardiovascular. Can it be a renal problem?
Absolutely, sir. Something like uremia, sir, can present with altered mental status, can cause vomiting and diaphoresis, sir. Absolutely.
Very good. Now, that is a long drawn process, but remember, in urine, urinary tract infection, especially the upper urinary tract infection, I'm talking about the acute one, not only the chronic, as Nilan said. Acute upper urinary tract infection, pyonephrosis or whatever, would present with vomiting. So the domain of vomiting is very large and it could be difficult. Please go ahead.
Yes, sir. So I thought of sharing a little schema I came across, sir, on the internet, sir. It's a very interesting schema for altered mental status specifically. Uh, so altered mental status, the causes for altered mental status can be divided into four little buckets, sir. The first we can say metabolic causes of altered mental status. So something like hyponatremia, hypohyperkalemia, hypercalcemia, something like we see in hyperparathyroidism, sir, the cyclic mons, phosphate and magnesium abnormalities, something like hypoglycemia, sir. It's very common. Uremia and acute liver failure, sir. In these all conditions, broadly, we can have altered mental status. The second bucket I would like to touch upon, sir, is the infectious causes. In infectious causes, sir, encephalitis. Meningitis, in some aspect, can cause altered mental status, sir. For example, if we have a case of TB meningitis, sir, with vascular infarcts going in. So, meningitis can, in some cases, also present with altered mental status. However, it is not very typical of it. We can have it in primary CNS vasculitis. It's not per se infectious, but I wanted to put it here. And also in cases of pneumonia and UTI. So, you mentioned UTI, I believe, so. Yes, sir. So pneumonia can cause it in more than one way, sir. For example, pneumonia-induced SIADH can cause altered mental status, or pneumonia throwing or septic emboli can cause altered mental status. The third bucket I would go is systemic infections, is systemic causes. Something like we will touch upon every organ in the body except the brain in this bucket. First would be infectious endocarditis, throwing septic emboli. Second could be Cushing syndrome. We know Cushing syndrome is known for causing psychogenic features, clinical features. Something like Addison's crisis, hyperparathyroidism. I covered it in hypercalcemia. Something like in post-stroke. Post-stroke patients can present with altered mental status and also in migraine aura. The last bucket, which is very important given the age of the patient is 59 years old, is traumatic causes. Traumatic causes, especially the subdural hemorrhage, can present with lucent periods. For example, patient had trauma, the patient recovered, but the bleed in the brain is continuously growing, and now the patient suddenly presented with altered mental status. So these are the four main buckets in which we can put the altered mental status at. So I had few thoughts to present on the first helicopter. When we say vomiting and altered mental status, so let's tackle it one by one. So we have tackled altered mental status, we can tackle vomiting. Now, vomiting can be something related to GI. So, person may have had food poisoning, or something related to brain. For example, a mass or a tumor pressing on the nucleus ambiguous, basically the nucleus vagus nerve. So, anywhere along, if the vagus nerve is stimulated, vomiting can have happened. Diaphoresis to my brain just reflects a sympathetic nervous system involvement, sir. In this case, since there is vomiting, so diaphoresis can indicate some sort of hypovolemia that is causing sympathetic nervous system involvement, or it can be a primary sympathetic nervous system involvement in terms of autonomic dysfunction. If we add up autonomic dysfunction with altered mental status, we are entering into the world of CNS etiology, sir. It's too vast to cover. So I'll assume in this case, sir, we have a diaphoresis secondary to vomiting, and then there is a pathology C, which is causing both vomiting and altered mental status. So that was my
Okay.
thoughts when I was doing through this, sir.
Okay, good. There was a short electric failure in our office. Please go ahead.
So should I repeat, sir?
No. It's go ahead. Go ahead. I could see some of the slides.
Okay, sir. So coming on to Aliquot number 2, sir. Aliquot number 2 will give us the rest of the history of the patient. So I'll wait for the slide to upload. Okay. So 3 days back, the patient developed vomiting, diaphoresis, and a complaint of increasing fatigue while the patient was traveling. 2 days back, that is 1 day after the complaint started, he reported having fevers for which he took an aspirin. On the same night, he was found in his room by his wife as non-verbal and unable to stand, but he was able to respond to painful stimuli. The paramedics were subsequently called. The paramedic took his vitals as blood pressure of 132 by 82 millimeters of mercury, pulse rate of 132 beats per minute, respiratory rate of 26 breaths per minute, with 94% oxygen saturation on 2 liters of oxygen per minute. The patient was febrile at 40 degrees Celsius. The pupils were non-reactive at 3 millimeters. The blood glucose was recorded to be 148 milligram percentage. So we have potentially ruled out hypoglycemia for that purpose, diabetic ketoacidosis from a single measure. Uh, Continuing on, uh, he was managed at a local hospital and he was referred to our hospital today. We could see some slight recovery in his condition, sir. He now reported feeling awful with diffuse muscle pain, neck stiffness, and pain while swallowing, but without any headache or rash. He appeared withdrawn and confused. Speech was slow, but he was able to follow commands. A quick tox screen came out to be negative. Continuing on, he reported no recent dental work and no unusual exposures such as tick or mosquito bites. A mention of ticks in this case is essential, sir, because the NEJM magazines are usually picks a case from which is endemic in US. So tick exposure is very important in this case. He has a history of gout, but he is not taking. He's currently not on any medications before the current illness. He has no known allergies. He drinks alcohol occasionally, but does not smoke or does not use any illicit drugs. And that would be the end of aliquot number 2, sir. I will go to the first slide. Yes, sir.
So would you like to make a comment on aliquot 2, or will somebody else like to make a comment on aliquot 2?
Maybe we can
Good
wait.
morning, sir. So my name is Pariniti, and what I could make out from the second aliquot was the things highlighting in the on the screen for me were basically he has a very high temperature, and he also has neck stiffness, and I think there's also a travel history to somewhere. So I would be thinking about some infectious cause which is causing his symptoms. And neck stiffness for me, basically it kind of translates to something like meningeal signs. So maybe I would be thinking about meningitis.
क्लास चल रही है अभी क्लास चल रही है 1 बजे तक. Yeah, please. So Parinita, you're right. So first thing is, as I was saying, your mind should start working like Sherlock Holmes. So once it is there, and she has told you, Parinita has told you that temperature being there, once there is fever, one thinks of infection as the commonest cause. So 9 out of 10 cases of fever, 8 to 9 out of 10 cases of fever would have infection as a cause. Remember that there is a small possibility that fever is not from infection. Can anybody just name a couple of conditions where there is no infection but fever is there?
The inflammatory causes like connective tissue disorders like rheumatoid arthritis and basically the autoimmune conditions.
Reha Vasan has written autoimmune conditions. Any other? So autoimmune is very important. And in that, remember, SLE, rheumatoid, all they come in, but the most prominent one is Still's disease. So that is one autoimmune. Any other condition which can cause fever without infection? Oh yeah, vasculitis, toxic, hypothalamic hemorrhage, central causes of fever, yes. And drug causes of fever, endocrine causes of fever. So there are so many. So I think from this aliquot 2, we are able to think that it may be infection. Of course, there is a 10 to 20% chance that it may not be, but the clinical dictum works on a principle of clinical epidemiology called Bayes theorem. Things which are more likely to be there are likely to be present in a given case. So I agree with this, and we will proceed further to aliquot 3. Nilayan, take over.
Yes, sir. So just to add on the fever, sir, when I think of fever, sir, I think of inflammation, sir. And with inflammation, I think of 5 things. Number 1 is infection, sir, as everyone pointed out. Number 2, it could be malignancy, sir, as also pointed out, sir. It can also be autoimmune, as Riniti pointed out. It can also be drug-induced, as someone in the chat pointed out, sir. But I think what everyone wishes is endocrine causes, sir. Endocrine causes can also cause fever. Something like thyrotoxicosis. So I think that's very important to take in mind, sir. And so presenting my thoughts on this one. So the first line suggests vomiting, diaphoresis, and increasing fatigue while traveling, sir. With this, my mind just went on to gastroenteritis because it's very common. The person might have eaten something from outside, got a bad case of gastroenteritis, and now is presenting with vomiting and diaphoresis. Depending on the time from which he ate and the time, depending on the time between him eating and vomiting, it could be something like a pre-made toxin, something like Staph aureus or Bacillus cereus, or something the bacteria made in his gut, could be Shigella, Salmonella. We have so many causes are there. So second line says he reported fever for which he took aspirin. So now my mind goes to something that aspirin caused. We know the patient had vomiting. So aspirin couldn't have caused vomiting because aspirin came after vomiting. But ultimately, aspirin can cause a liver failure. We know aspirin can cause liver failure. Actually, it's more of paracetamol. Aspirin can cause, renal failure. So maybe I will look out for that in future. The patient is non-verbal unresponsive. The patient has some sort of encephalopathy. I'm not sure what to make of that as of now. His temperature is very high and his respiratory rate is very high with a low oxygen saturation. This just makes me think something like pneumonia. Adding pneumonia with a gastroenteritis symptom, I'm thinking of Legionella, something like Legionella, sir. But at the same time, yeah, I don't have anything to go on from these two lines. So moving on to the next slide, sir. Diffuse muscle pain, neck stiffness, and pain with swallowing. So muscle pain is just myalgia, but neck stiffness, okay, neck stiffness in vertical planes reflect meningitis because of the stretch of the inflamed meninges. Pain with swallowing can be interpreted in many ways, but I thought of myalgia. So we have myalgia, we have a stigmata of meningitis, something suggestive of meningitis, but it doesn't add up. For example, if we think of meningitis here, we think of myalgia here, then we had some sort of pneumonia-like picture going on, something like gastroenteritis. So with these two pages, I couldn't make a uniform theory that connects them all, the Occam's razor we talk about. So that was my assessment of these two slides, sir. Like I couldn't just make a uniform theory.
Yes, any opinions on that? The third aliquot.
Sir, I think the respiratory pneumonia would be highly unlikely because there's no cough or any such symptom along with the fever. And also the changes that, Nilan, could you move to the previous slide? The changes that he's saying in the respiratory rate and everything that could also be as a result or response to fever. And oxygen saturation can go down in some cardiac causes too. So because he has taken aspirin as well, so could be because of some bleed or something like that due to aspirin.
Okay, so Nilan, can it be an intracranial pathology? Because this difficulty, painful swallowing actually is dysphagia. So you have dysphagia with neck stiffness, with myalgia, with vomiting and confusion. So could it be anything intracranial? Remember, we said fever, infection is the most likely, but then intracranial pathology, especially affecting hypothalamus or whatever temperature control region, would also be responsible.
Yes, sir, absolutely, sir. So we can have CNS pathology, sir. If it's primary or secondary, sir, it has to be secondary because we cannot have infection in the CNS like in situ, sir. There has to be some portal, and we have to look out for what portal the bacteria used or the virus used to gain access to the brain. Maybe through the GI tract, the patient was complaining of gastroenteritis-like symptoms. Maybe a pneumonia hiding because the respiratory rate was very high and the oxygen saturation was sort of low, even on oxygen. Maybe a UTI which we haven't discovered yet, improbable but possible, sir. Could be a bacteremia, could be a cellulitis we haven't looked up, could be a colitis, could be a cholangitis, sir. Basically, sir, yes, sir, we have features of CNS involvement, sir, but we have to look out where the primary is hiding, sir. Because primary CNS involvement, I'm not sure, sir, how can that happen?
So can it be a bleeding, hemorrhage? Raghav Gera has written query hypothalamus hemorrhage Ragini says malignancy. So they are giving you alternative to infection, and CNS hemorrhage would present acutely like a stroke.
It can, sir. It can, sir. So, but how do we explain? In that case, if it's a CNS hemorrhage, sir, then the vomiting and the diaphoresis a day back would be purely coincidental, and the low oxygen saturation would not also be explained, sir. I mean, how do we marry these two?
So the question was raised, there is no pneumonia because there are no symptoms. So one is that for having pneumonia at this age, you don't need to always have the symptoms. The second thing one should keep in mind is when there is dysphagia, and you see dysphagia so commonly with stroke. Stroke is a very common manifestation. It is 1/6 of our admissions in medical wards is from the stroke. And strokes are very often associated with dysphagia. And once there is dysphagia, that is a precursor to the complication of pneumonia from aspiration. So that's very, very likely. And you don't always have to have a cough and other symptoms, especially in a person who is confused. So there could be many reasons, and 94% is okay. I don't know how bad do you think is 94. Was he a smoker? You will tell us later. Okay, please go to your relay code 4.
Yes, sir. So the patient wasn't not a smoker, sir. Did not smoke.
Okay.
So moving on to Aliquot number 3, sir, I will discuss few of the physical findings in this aliquot, sir. So the patient was lethargic, diaphoretic, flushed, and was unable to sit up. In the cardiovascular system, sir, S1 and S2 were normal without any rubs, murmurs, or bruit. In the abdominal examination, bowel sounds were present, were normal. The abdomen was soft, without tenderness, distension, or organomegaly. The skin was mottled, and there was a rash in the libido pattern on the arms, legs, chest, and abdomen, and a purpuric rash on the hands. The hand and feet were initially cold, and the muscles were diffusely tender. So I have a picture to show everyone. So this is what I meant by libido pattern. Libido pattern, it's actually libido reticularis. So reticularis translates to net-like pattern. I'm not sure if this picture conveys that very properly, but you can see a lacy net-like pattern of this rash. So moving on the CNS examination, the patient was oriented, but his memory of recent events was impaired. He could follow only stepwise commands. Speech was fluent without paraphasic errors. There was diffuse generalized weakness. The deep tendon reflexes were mute in the ankle, and otherwise 1 to 2 plus plantar reflex. 1 to 2 plus plantar reflexes were flexor. And that is the end of aliquot number 3, sir.
Any comments?
So looking at aliquot number 3, what strikes to me most was the skin and the muscle, like the skin exam. Livedo, like skin is also involved, and the muscles also are tender. Like in normal myalgias, I don't think muscles are tender. So like this, like it feels like the muscles are getting more affected. So I would be thinking of something systemic which is causing it. So like the only organ which goes to all parts of our bodies is the blood. So like I'll be thinking about some maybe autoimmune vasculitis kind of thing, which is affecting all the systems like skin and muscles, and even the CNS to some extent. And another thing which strikes to me is the speech is normal. So I don't know if then the dysphagia we would attribute it to a CNS cause, because like CNS would usually cause like a paralysis of the pharyngeal muscles. So if the speech is normal, so I would like to like attribute the dysphagia to some other cause right now, I think.
So I can see that Riya Vasan has been dissecting the case right from the beginning, and she has been putting her comments out time and again. And one of the things that she put out a couple of minutes earlier was, could it be septic emboli?
Absolutely, sir.
With
Can be.
livido So you don't have to think of autoimmune all the time. And these sepsis conditions also can be very, very difficult and can be very damaging. Okay. The other is somebody says Pragya Nil. DVT, query platelet disorder, DVT causing stroke. What does that mean? DVT causing paradoxical stroke, is it? Okay. Could it be platelet disorder, Nilan? Pragya is asking.
Platelet disorders would, okay, we have two things in platelet disorder. Either it could be excess of clotting or it could be lack of clotting, sir. Excess of clotting with platelet disorder, I would think something of myeloproliferative disorder, something that they are producing platelet in so much quantities so that the blood vessels are getting clogged. It usually doesn't present as a stroke. I mean, we know of hyperviscosity syndromes, but I don't think it presents something like this, sir. And if she meant something like lack of platelets, that is a bleeding disorder, then again, sir, bleeding disorder, we can explain the CNS manifestations, but how do we account for the skin rash, or the gastroenteritis, or the low pulse oxygen, low oxygen saturation?
No, Nilan, Pragya probably was referring to the libido reticularis picture that you showed.
Yes,
Probably
sir, yes, sir.
Can it be one of the platelet disorder manifestation?
Sir, the libido reticularis, it can be, sir. It can be. Totally can be, sir. We know of something called TTP, sir. TTP, thrombocytopenic purpura. Basically, sir, skin involvement shows a small vessel involvement, sir. And anything that affects small vessel can cause this pattern. So I totally agree. A platelet disorder can manifest in this way. It will also explain the CNS manifestations. Okay, yes, sir, I agree. It can be a possibility.
I think the platelet and vascular disorder manifesting as bleeding or bleeding like clinical presentation is often confused, and it's very difficult to separate out platelet disorder from vascular disorders when it comes to bleeding. The only thing is, if you do the platelet count, you can find out there is thrombocytopenia, but then those disorders where platelet function is affected may not be picked up there, and you cannot separate them out from vascular disorders. But if the pattern is like vascular, then that will be more like vascular, whereas platelet would cause either ecchymosis or petechiae, that kind of a bleeding, or a mucosal bleed. So I will not think so much on platelet disorder, even though platelet number could be low whenever there is infection. Okay, please go ahead. Let's go.
Can I add something, sir? Riya Vasan.
Yes, I think there is something more. Sorry, who is that?
Sir, Riya Vasan.
Yeah, tell me, Ria.
Sir, I was thinking that this can be a viral infection like COVID, which is causing hypercoagulation, thus libido reticularis, and encephalopathy and myopathy can also be a feature of COVID.
So, Nilan, how do you react to that? That's very interesting. You know, Ria is almost, as I said, she is dissecting everything so well. Everything fits into COVID, she said.
So COVID is an interesting thought, which I absolutely didn't thought of. It is a possibility here, sir. It is possible.
I think it will depend on the scenario. That is why it is important when this incident took place. If it took place in the last 2 years, it is possibility. But if it was 10 years, then it is not a possibility. And I think he has picked up something historically and it came from there. And that brings us to the same clinical epidemiology which I speak about. During the past 1 year, any fever that has occurred in our city, state, or country would be construed as COVID unless proved otherwise. And let me tell you, it is so difficult to prove it otherwise with the available tests. So we would agree on that. But if we find out that this history belongs to a person who has not been exposed to, environmentally exposed to a condition of COVID, then that probably will not be thought of so much. So it makes so much difference. Yes. And there is something that is coming from Richa saying acute liver failure leads to coagulopathy and encephalopathy. Why do you leave your liver problem out? You mentioned it in the beginning.
It is possible, sir. Liver failure leads to encephalopathy, I agree. And coagulopathy in terms of vitamin K dependent factors. Sir, as we learned only yesterday, sir, in we have okay. In coagulopathy,
Yes.
sir, we have either platelet dependent disorders or we can have clotting factors dependent disorders. So platelet disorders usually manifest in the form of petechiae and purpura. Basically, skin manifestations are more common, and the disorders involving the clotting factors usually present something as hematorosis or deep hematomas. So it would be less likely, sir. You are more experienced, so you will be able to relay much better.
The liver disorders and the clotting factor disorders versus platelet/vascular disorders, there is a clear distinction clinically. But remember that clinical distinction is only a guideline. So one particular bleed, you cannot attribute 100% to a platelet or a vascular versus clotting factor disorders. So the clotting factor disorders can also have ecchymosis, and you can have muscular bleeds even in platelet or vascular disorders. Having said it, if you have something like, the bleeding that occurs in clotting or platelet disorders does not respect any vascular territories. It is just random. It goes across the anatomical boundaries. So you can have small dot-like bleeds in petechiae or larger ones, ecchymosis, or subcutaneous ones like hematomas or wherever it occurs, mucosal ones. But the reticularist-like pattern tends to suggest that there is probably involvement of the vascular system, probably the capillary system in the pre-capillary system. So that kind of involvement would be more like this. But liver disorder is difficult to rule out, but nothing positively coming in favor of it. It does not mean that it should not be considered. So it can be considered, and actually, I think Nilayan put it right in the beginning that when there is confusion and vomiting, then liver disorder he would think of. There is something has come from Pratik. He says, what do you think of the inability to sit up? You said he was unable to sit up. Does it suggest proximal muscle weakness?
So I thought about it, sir, and I had two thoughts regarding it. First of all, sir, inability to stand up reflects some sort of proximal weakness, which I agree with Pratik. But proximal weakness can be a manifestation of a disorder anywhere from brain to spinal cord to peripheral nerves to neuromuscular junction disorders to muscle itself, sir. For example, sir, if we have a parasagittal meningioma, then it might press upon both bilateral representation, bilateral hemispheres where the thigh muscles are represented, and it can cause weakness that way. If we have some sort of spinal cord disorder, then it can also present with bilateral proximal weakness. If we have a neuropathy, sir, some neuropathies also present with proximal weakness more than distal weakness. It can be some sort of myopathy, sir. In this case, I was not able to pinpoint if it's a true case of myalgia or a myopathy if the patient is experiencing so much pain that the patient doesn't even want to stand up, or the patient does not even understand what we are trying to relay, or something like, sir, in GCS scale we have EVM, and what if the M is not high enough for the patient to follow our commands there? So those were my thoughts when I thought about inability to stand up.
Okay, so you did consider myopathy. Now Sarthak Miglani is raising another issue. You considered myopathy, and you have a skin involvement, would you consider dermatomyositis as one of the differential?
Yes, totally possible, sir. But dermatomyositis with the CNS involvement, it is also possible. So dermatomyositis can be primary, can be secondary. If it's secondary, it can be secondary to a cancer. If the cancer is causing CNS manifestation, and then we are seeing the peripheral manifestation of dermatomyositis, then we can have this sort of pictures of. Okay, it is a possibility.
Yeah, the only thing is in dermatomyositis, the dermal involvement is not like livedo reticularis. So there are usually very characteristic skin involvement, periorbital or the hue that you see there. And dermal involvement, though, can be of any kind, but not the livedo reticularis. So there are many, but we have to give the priority now. Please go ahead.
Sure, sir. So I think we can all agree, sir, that this form of dermal involvement in the form of livedo reticularis reflects a small vessel vasculopathy. We don't know if it's through inflammation of the vessel itself, if it's obstructive vasculopathy, some sort of, as someone suggested, platelets or clotting factors getting involved, or if it's an infection causing vasculitis. So at this point, sir, seeing the skin involvement we had, I thought of these three major possibilities we have right now. The vessel involvement would also explain the CNS picture we had. And so vessels truly can get inflamed anywhere. So we have small vessels everywhere in the body, sir. So it can also explain some sort of gastroenteritis. It can explain some sort of pneumonia. It can explain the dermal involvement and the CNS involvement. So I thought vasculitis sort of makes sense since we discussed it can also present with fevers. So those were my thoughts at this particular point, sir.
Okay, good. We'll accept that and we'll just convey to the rest of the audience. Reha Wasson has again put out that dermatomyositis, you can see a characteristic heliotrope rash and other things you have discussed. Okay, please go ahead.
Yes, sir. So moving on to aliquot number 4, sir, we move on to investigation, sir. And I have two tables to present here. I'll run everyone through it. So we see hematocrit is slightly low. I'll zoom it in, sir, if it's okay.
Yeah. I think you zoom it in because now it is okay.
So we see hematocrit is slightly on the lower side. Hemoglobin is 12.5, which in a 59-year-old man is sort of worrying for me. I was thinking just on base of these two values, something like hemolysis or an occult GI bleed. In a 59-year-old man, sir, with the low hemoglobin, so the first thought that crosses my mind is colon cancer. So based on these two points, I thought of that. We have a low WBC of the WBC count is normal. Differentials, we see a neutrophil is slightly on the higher side, is actually very high, like much beyond the range. Platelet count is low and very, very low. We see ESR raised, so some sort of inflammation. We figured that out. Peripheral smears show some sort of teardrop cells, but it's just 1+, so I wouldn't read much into that. The prothrombin time is slightly raised. Fibrinogen is very, very raised. Sodium is okay. Potassium is okay. Chloride is okay. Carbon dioxide is very, very low. Anion gap is okay. And we see BUN and creatinine heavy. We see creatinine of 3.4, BUN of 53, BUN by creatinine of more than 20. So some sort of less than 20. So some sort of intrarenal pathology going on. And GFR, okay, that's not important. Bilirubin, total of 3.2, direct of 2.6. So indirect was just 0.6. So that puts hemolysis out of question here. So just says teardrop cells is just incidental finding. And this is the second box of investigations. My focus was on ALT and AST, both were raised, some sort of liver involvement as well. LDH is very high, creatinine kinase is very high. Though we have many sources of creatinine kinase, it might explain the myalgia the patient was having. CKMB is specific for heart, which is also raised. Troponin is raised. So, and pH is normal. And we see PCO2 is low. And that's it. I had highlighted some major points here. So the lactate was elevated. We saw bicarbonate was decreased. Renal and liver functions were elevated. We saw that. Testing for occult blood in the stool was positive. So this might explain the low hemoglobin we had. No intracellular or extracellular organisms were seen in the examination of peripheral blood smear. So just ruling out some sort of malaria babesia. Chest X-ray was normal. CT images of brain, abdomen, pelvis obtained without the administration of contrast was also normal. Urine analysis. Since we had a altered kidney function, sir, it made sense to have a quick urine analysis. Specific gravity of 1.025, so we know the tubules are working all right. pH is okay. 1 plus bilirubin, 2 plus albumin, and 3 plus occult blood by dipstick. So I'm worried here. Examination of sediment revealed 3 to 5 RBCs, 3 to 5 WBCs, few bacteria, very few tubular cells, amorphous crystals make sense because the patient had gout, and that's it.
Good. So that's very interesting, very fascinating, good learning slide. I would invite comments. So before we go to that, somebody says respiratory examination wasn't included, was it?
No, sir. Sir, I think I can explain the recipe findings with my investigations only.
Okay, right. So you have actually, because for want of time, you have just left them out.
Yes, sir.
Okay. Right. Any more? No more? How is that?
So this is Parinati. So from the lab investigations, what I could make out, like it is some sort of a DIC like picture is happening, because we see that the platelets are low and the fibrinogen is high. So like it's like sort of a consumptive coagulopathy kind of thing happening, and also there are teardrop cells and there's low HB. Although the low hemoglobin could be because of the occult GI loss. There's like a microcyto Maha like picture basically we can see in this. So I think in the last aliquot also we sort of narrowed it down to the vessels. So now we just have to see like what is causing this diffuse vessel involvement and DIC like picture in this case.
Okay. Anybody else has a good opinion on that? So do you get elevated bilirubin in DIC?
No, sir. But like maybe because of the breaking of like hemolysis of few RBCs, maybe the bilirubin could be raised. Although I'm not so sure.
Okay, so let me see if any comments have come. Fibrinogen and ESR are acute phase reactants. Likely TTP. Sarthak says systemic inflammation seems to be happening, raised fibrinogen, impaired multi-organ dysfunction. And is from Raghav, and Reha was saying impaired. So, there are a couple of things we should keep in mind when we are looking at the science. When we are looking at the investigation, let us look at them independently. And what comes out, let us try to gel it with what we have gone through during the previous aliquots. So history, examination, whatever, then you gel it with that. So what strikes out is the line started by saying, oh, I'm not happy with hemoglobin of 12.5. So 12.5, whether you're in US or you're in India, one should not be happy with if it is in an adult male. Adult male would be anemic if anything under 13 grams per deciliter is a hemoglobin. Usually you would expect 14, 15, 16 also, or even more. So hemoglobin is low, platelets are low, and actually if you look at it, there is a TLC which is normal, but the breakup we will talk about is also showing something which is low. So when 2 out of 3 elements are down, you call it pancytopenia. And that makes your life easier actually. Because pancytopenia is a constellation which leads you into differential diagnosis of different kinds. So if there is a pancytopenia, one can think of, oh, could it be aplastic? There is no organomegaly, and there are so many causes of aplastic, idiopathic, drug-induced, systemic disease-induced, whatever. Or it could be a bone marrow infiltration, myelophthic kind of this pancytopenia that you can see. Or a autoimmune, you have been considering autoimmune all this way through. So that could be another reason for it. Drug-induced is another one, hypersplenism is another one. And of course, in our country, you do see pancytopenia from something called megaloblastic anemia. And we see it very commonly because of the dietary deficiencies or the condition folate deficiency or dietary B12 deficiency. In the West, they would be seeing more like pernicious anemia. Now, when we are in this pancytopenia, the peripheral smear of polychromasia and teardrop cells tells us the turnover is very fast. So it cannot be aplastic. It is something which is where the bone marrow is reacting and the destruction is likely to be peripheral. And when you look into the 6,000 of TLC, actually the neutrophils are normal. Neutrophils are not elevated. And this particular thing they should do away with. I have not been able to get these labs do away with this percentage differential counts, which is misleading. So if you look at the neutrophil count, percentages have no meaning. 80% of 6,000 comes to 4,800, which is a normal count. But at the same time, 8% of 6,000, which would be 480, would be a low lymphocyte count. So there is lymphopenia. So there is what I will call a pancytopenia, lymphopenia, hyperactive marrow, a deranged prothrombin time, fibrinogen is probably non-specific, as I said. So these parameters tend to suggest that something is not going on well. It is not likely to be a primary hematological disease, but it is certainly manifesting in this. All these sepsis that occurs, 60% of the infections are associated with DIC. And if you have a frank sepsis where you're considering septic emboli also, then it probably would be 80 to 90%. Now, the way to look at DIC is you have a clotting process that is going on within the system, and you have a bleeding at the same time that is going on. And the hallmark of DIC is elevated D-dimers. And fibrinogen can be low if it is consumed, but if it is reactive, it can still be high. But high fibrinogen is not a usual feature of severe DIC. Peripheral smear gives away because of a microangiopathic type of picture, which one could say maybe if they have not given the details of the peripheral blood smear, but then this will go with it. So all in all, there are blood counts that are low. There is lymphopenia, there is pancytopenia, and there is a reactive marrow. Can you just move the slide up? Let me see the other ones. ALT, AST. Yeah, a little more. And there is a direct hyperbilirubinemia. Is there something more also?
Yes, sir. So, next slide would be this.
Yeah, one second. And there is metabolic acidosis. I think I would have expected somebody to say when you're doing this bicarbonate deficit, then there would be a metabolic acid. That explains the respiratory rate of 26. So in this patient, there is high-grade fever, whether it is infection or autoimmune, there is associated reactivity in the body. Somebody was talking about COVID, and it has given rise to a metabolic acidosis, which is known systemic complication under these circumstances. ALT, AST of 2-3 times could be non-specific, and so also the elevation of LDH. Creatinine kinase will go with the muscle pains and myalgias, but if it is what percent would that be? 10%? No, 1% is MB. So that means there is a infection is involving severe muscle pains. Is it a, as Nilayan said, a food poisoning which causes severe myalgias also, muscle involvement also, or is it some other sepsis we would really have to look at? Okay, the lactate level was elevated, which suggests that there is acidosis at the cellular level, and the bicarbonate decrease is systemic metabolic acidosis, and the stool occult blood was positive. Okay, please go ahead. Next slide.
So, sir, should I? Okay, sir, I had few points to make here, sir. As someone pointed out,
Please.
why didn't we do the recipe examination, sir? And that I can explain by the fact, sir, we have metabolic acidosis here. We can very clearly see a base deficit. What I thought was meant by increased respiratory rate was a respiratory compensation, sir. We see a low CO2, we see an acidosis. We don't see an acidosis, sir. Actually, it is compensated now. But the fact that we have metabolic we have base deficit indicates a metabolic acidosis with a compensatory respiratory alkalosis. So that explains the high respiratory rate, sir. But then what explains the low oxygen saturation, sir? That might be secondary to the cardiac involvement, sir. We see that troponins are high. We see the CK-MB are high. So there is a possibility of a MI-like picture. We just know the muscle is the cardiac muscle is dying or has died, but we don't know if it's truly an MI in the true sense or if it's something else. If it's a vasculitis of some sort, if it's a it's a myositis of some sort, yeah. So that explained the recipe, the tachypnea to me. And so we see the AST, ALT are high. So simultaneously, we have kidney involvement, we have liver involvement, we have heart involvement, we have brain involvement, we have dermal involvement, and then we had a gastroenteritis sort of picture initially. So what essentially connects these all system, and that too simultaneously. So an infection would explain, okay, I accept infections could be it, number one. Number two, blood, sir. The only thing that connects these many organs is blood. Nothing connects these many organs. So one thing to consider is blood. One thing could be vessels, blood vessels. If there is blood, then there has to be blood vessels also. And sir, I would like to remind that the skin manifestation, we concluded it as being a small vessel vasculopathy. So this is some sort of small vessel vasculopathy. We don't know if it's a primary vessel itself or it's the blood that's faulty, some sort of DIC or HUS or TTP-like picture that is causing all this manifestation.
So somebody says there is blood in the urine.
Yes, sir. So blood in urine, okay. So we had blood in urine that could be, okay, I don't want to say, but sir, we had a kidney involvement, right, sir? So any sort of glomerular nephritis or a vascular insult to kidney can result in blood in urine, sir. That's and also the patient had gout. So
And what about low platelets? You said you were commenting very, very low platelets.
Yes, sir. So that's the final nail in the coffin, sir. We have a picture of thrombocytopenia. Now we don't know if it's consumptive or if it's a primary bone marrow involvement. However, that's a little less likely because the hemoglobin was sort of normal. Like it wasn't that abnormal. And we have also have lymphopenia sort of picture, sir, that I absolutely didn't know how to interpret that, and I was totally blown away by that interpretation, sir. That the percentage is absolutely useless. So yes, we have thrombocytopenia, we have sort of lymphopenia, we have a diffuse vascular involvement, and that's all I can say at this point, sir. So our differentials would include all sort of vasculopathy, whether it's the vessels itself, that is vasculitis, or if it's something in the blood, something like an infection or the platelets doing the trick.
So there are two things here. Raghav wants to come in and say, could just be simply myocarditis as a part of a systemic inflammation from whatever cause?
So myocarditis can be like we cannot explain everything by myocarditis, but we can explain the heart manifestations by myocarditis. So myocarditis could be one of the things that's going on in the body. With myocarditis, I cannot explain the liver or kidney or the brain or the dermal or the skin involvement. So myocarditis fits in the context of heart involvement, but not the whole body.
Maybe heart is not keeping up with the body requirements. What is the hallmark of DIC, Purva Mehta?
With DIC, sir, I think of consumptive coagulopathy, sir.
Yeah. What is the hallmark of DIC?
At one point, sir, we have florid clotting, sir. The patient will have clots everywhere, but then the patient would run out of platelets on and coagulation factor, so the patient will have simultaneous bleeding and clotting going on in the same body.
So the hallmark of DIC, yeah, sorry, please go ahead.
So that's all.
So the hallmark of DIC is clot process going on and consumption going on, which leads to bleeding. It's a very strange situation that in the same body at the same time you have thrombosis going on somewhere and bleeding going on somewhere else. So when you have a clot process going on, then that causes the clot to be taken away by the thrombolytic process. And that gives rise to the generation of FDPs and D dimers. Actually, D dimers are the one which come out of the clot, and FDPs may not necessarily have a clot behind them. So D dimer, if it is elevated, would suggest that there is a thrombotic process. Now you have to show that there is a clotting disturbance also, bleeding process also. Platelets can be low. There could be consumption of these clotting factors, and including the fibrinogen. Though once they are consumed, then they try to rebound and they come to be normal. So the hallmark of DIC would be 3: elevated elevated D dimer, low platelets, low consumption in the form of altered clotting test, PT, APTT, and the third would be the blood smear, because once you have this microangiopathy clotting process going on, there would be a microangiopathic kind of anemia. So 3 things that you should look for. Okay, so okay, right, please go ahead.
Yes, sir. Sir, and we can see the PT, sir, the prothrombin time is just mildly raised, sir. And teardrop cells, though are present, they are just 1+, which could purely be some sort of processing anomaly. So, sir, we can safely sort of rule out DIC in this scenario, sir.
No, we cannot rule out. You see, teardrop cells by itself may not mean so much. Teardrop cells you can see in many conditions, whether it is hemoglobinopathy that we see, or even iron deficiency that we see, or some of those hepatorenal things. Hepatorenal, you usually see a different kind of cell. Polychromasia is just indicating that there is something going on. So these two combinations that you actually see on the smear would tend to suggest that there may be an ongoing bleeding. So if you look at the stool occult blood, which was positive, if there is a chronic blood loss, that will cause iron deficiency. In fact, I was surprised that they have not given a MCV here. Mean corpuscular volume is something that automatically comes in. I was actually looking for it. And if you find that it is low, then everything will fit into an iron deficiency from a chronic ongoing blood loss.
Okay, sir. Got it. So, moving on to aliquot number 5, which will give us a diagnosis, sir. An investigation was done to diagnose the condition, what the patient had. Any guesses in the chat box to ask what the investigation might have been?
So Rhea Watson has put her money on sepsis and vasculitis would be my top differential diagnosis.
So to diagnose vasculitis, the investigation would be biopsy.
One second. No, Pragya says, was it angiography? And Nikita says, was it echo that was done? And a blood culture is from Rahul. Yeah, please go ahead.
Okay, sir. So a blood culture was done, which came out to be negative on 2 occasions. LP couldn't be done because the platelets were too low. However, I didn't very much agree with this statement, but that's how it was put. A transthoracic echocardiography came out to be positive for a vegetation that was found on the ventricular aspect of aortic valve, a mild MR, and a mild to moderate TR. Aortic root was not dilated, which is essential to mention since the aortic valve was involved, there were no evidence of vegetation on the mitral, tricuspid, or pulmonary valves, and no evidence of aortic root abscess. I also have a picture to show everyone. So this is the vegetation they saw. This is the aortic, this is the LVOT. This is the, okay, I realize that my pointer is not visible, sir. But the arrow points to a vegetation here.
Yeah.
So I think the diagnosis is fairly evident. We have endocarditis, infectious endocarditis. We have Liebman-Sachs endocarditis, indicating the patient might have SLE. Culture negative endocarditis. Okay. So should I move on? Okay. So the final diagnosis was infective endocarditis, and they kept the possible differentials of RMSF, Rocky Mountain spotted fever, which is not applicable in the context of India because we don't have that tick in India. And important differential they made were the small vessel diseases, and they classified this in 3 buckets. We have an obstructive pattern, a septic pattern, and a vasculitic pattern. In obstructive pattern, sir, we can think of something like APLA, TTP, DIC, and embolic phenomena. I guess except APLA, we discussed these 2. In the vasculitic phenomena, we can divide it into ANCA positive or ANCA negative, and we are keeping this as small vasculitis, small vessel vasculitis, because the dermal involvement indicated small vessel vasculitis, sir. So in that context, in ANCA positive vasculitis, we could have thought of MPAN, microcytic pan, Chuck-Strauss, GPA, also known as Wegener's, or the ANCA negative kinds, which is the HSP, the Henoch-Schönlein purpura, or the cryoglobulinemia type 2 and type 3, since type 1 presents with hyperviscosity like syndromes. The third vascular pathology, the third bucket of vascular pathology could be septic-like feature, something like meningococcemia or RMSF. But since RMSF is out of picture, so something like meningococcemia. So the question is, how do we effectively rule out these differentials, sir? So should I continue?
Yeah, please.
Okay. So for Chuck-Strauss, sir, we would have seen some sort of eosinophilia or asthma, even though they're not 100%, but the absence of those does make the pretest probability very, very low. For Wegener's, there were nothing, there were no upper respiratory sign, no upper respiratory involvement. So that just made it less likely. With MPAN, diffuse alveolar hemorrhage is a very common, is a noted feature, not present here. With TTP, we had no hemolysis per se because the indirect bilirubin was normal. We saw teardrop cells, but per se no hemolysis. And with APLA is actually a good thought, but the fact that there were no secondary autoimmune process going on, nothing suggestive of SLE, nothing suggestive of Sjogren's, no features suggestive of secondary autoimmune process here to suggest that APLA could be a thing here. And meningococcemia is literally too fast for this type of presentation, this type of subacute presentation. And
what do you mean by that? The last. What do you mean too fast for this?
So basically, so what I read was that meningococcemia, sir, typically decompensates very, very fast, sir. The patient decompensated over 3 to 5 days. Meningococcemia doesn't even give that much time, sir. That was what was implied, sir.
So you are saying that meningococcemia usually is faster than what this patient had?
Yes, sir. Yes, sir. The time course is much faster for meningococcemia, sir.
Okay, 2, 3, 4 days is okay. Right. Anything more you have to add?
Yes, sir. So, sir, a valid question here would be, why no murmurs? I'm saying we have MR, we have TR, we have aortic valve thrombus, but also I said there were no murmurs. A possible explanation is, sir, and it is, I was blown away, that the patient had tachycardia. And the tachycardia literally, tachycardia hides a murmur. So absence of murmur does not rule out infective endocarditis, and that was one of the pearls I took away from this case. And what was the source of bacterial invasion? We are saying infective endocarditis, but I haven't mentioned any possible source, right? Because there were no skin punctures I could see or no history of that. We had a history of occult GI bleed. So what was hypothesized was that bacteria migrated from the colon, and then it went to the bloodstream, and then it migrated to the heart valves. And uh, even though culture was not available, sir, uh, a possible case of GI malignancy, colonic malignancy, cannot be ruled out. Also, sir, strep bovis. Strep bovis is a commensal that is present in GI tract. A strep bovis infective endocarditis makes it essential for every clinician to rule out a colon cancer. Thrombocytopenia essentially rules out vasculitis, sir, because vasculitis is primarily an inflammation, sir. And thrombosis is an acute phase reaction to any sort of inflammation, sir. So if we see thrombocytopenia, it sort of rules out vasculitis, not exactly rules out, it just makes vasculitis less likely because we would naturally expect thrombosis. Thrombocytopenia is exactly opposite of thrombosis. And how do I explain the myocardial involvement or the kidney involvement or the liver involvement or the meningeal involvement? That is simple. Septic emboli. Septic emboli everywhere. Septic emboli in heart. Okay, the heart involvement can have two possible differentials. It could either be a septic emboli going into the coronary vessels, or it could be an abscess, a myocardial abscess. But myocardial abscess is less likely because we saw no aortic root abscesses. So we had basically in this patient had emboli from heart to kidney to lungs, or not lungs, to kidney to liver to brain, and infective endocarditis can also have intense myalgias. Though myositis is less common, in this case myositis was also seen, a proper myositis. And so the last point, I've already made this point, the tachypnea was compensated to metabolic acidosis caused by liver and kidney failure.
Very good, very good. Just a couple of points that came a little while earlier. When Pariniti wrote echo was probably the test to be done. Subsequently, she wrote culture negative endocarditis. Priyansh said Libman-Sachs endocarditis, and Rahul said infective endocarditis. And the problem was from Rukaya, how does infective endocarditis explain liver function test derangement? And raised bilirubin and ALT. And what is the meaning of obstructive from Purva? Would you like to react to that? Can infective endocarditis cause liver function derangement?
Yes, sir. Simple. A septic emboli, sir, basically. A septic emboli going to the liver. Also,
So,
sir,
yeah.
So basically, sepsis, in this case, the blood cultures were negative. However, we cannot rule out a negative blood culture endocarditis, which can still be a bacterial in origin. And a diffuse sepsis can cause some sort of stasis of the bile in the hepatic tree itself, which can explain the raised bilirubin, and the septic emboli can explain the AST and ALT.
Okay. So I think we must, take it in the proper perspective. We see a lot of endocarditis here in India, and it is somewhat different. We call it subacute bacterial endocarditis. Subacute bacterial endocarditis indicating that there is a pre-damaged wall, pre-deformed valve, and that is having this vegetation and bacteremia. And remember, even here, when we have subacute, we are not talking about acute infective endocarditis. Even in subacute, we say it's a medical emergency because the course is very fast, as you heard. If there is bacteria in the blood primarily and they are just circulating like that, they cause septicemia and all inflammatory markers and all intravascular destruction. Everything is occurring, and all organs, including liver or whatever, kidneys, can be involved. So the idea of differential of infective endocarditis can come in only after you have made the diagnosis of sepsis, bacterial sepsis. So in this case, if you make a diagnosis of bacterial sepsis and you don't have history of previous heart disease or a deformed valvular disease or a echo or a auscultatory finding, then you would not be able to say about the infective endocarditis. So primarily, I think the focus is if from this case you make a diagnosis of sepsis, with bacteremia, with multi-organ dysfunction, then that puts and explains a lot of things, including the DIC. And mind you, now I think the hemoglobin fall was probably from acute sepsis, which can cause some intravascular destruction. So if you check the reticulocyte count, it will be high in terms of that polychromasia, and if you check the haptoglobin, it would be low. So bacterial infection or sepsis occurring out of the blue when there is nothing in that particular patient, you have to concentrate on 3 or 4 organ systems. Is sepsis occurring like this in a male, one should think of 3 primary areas, and 4th I will tell you later. 3 are either the respiratory. So pneumonia, even if there is asymptomatic, but pneumonia is a common cause. Urinary or genitourinary is second, and third is skin and subcutaneous tissue. So if clinically you can see there is no skin and subcutaneous tissue infection, you land up concentrating on respiratory or genitourinary. Respiratory, you can do a good clinical examination, and even simple supportive investigations can be of help in large number of cases. Genitourinary, you can look for the tenderness, whatever, but urinary examination should give it away. So these 3 systems can easily be picked up in one of the aliquots, as Milan puts it, whether it is on the history or examination or the lab finding, 3 pillars of making a diagnosis. If you don't find it is there in these 3, then you have to think of that sepsis occurring from somewhere else. And those are rarer situations. And one of them would be a endocarditis becoming the nidus for giving rise to the vegetation of bacteria and causing bacterial sepsis. So it's a very good case, and I think it explains everything and it fits everything back into the features of whatever you have presented. And they did not find a positive culture. What happened to the case? They would have given a follow-up also on this.
Yes, sir. Yes, sir. So the patient, sir, the patient was started on antibiotics, sir, vancomycin and all. But unfortunately, sir, the vancomycin just worsened the kidney failure, and it just kept on worsening. They changed the antibiotic to daptomycin, but it just kept worsening, sir. So they did a kidney biopsy, and it showed acute interstitial nephritis. So the antibacterials were switched. They started on something else. I don't exactly remember, sir. And the patient was started on steroids. So after 6 weeks, and also, sir, the patient was administered a renal replacement therapy, that is dialysis, briefly, because of the acute kidney failure. So after 6 weeks, sir, the steroids were tapered off. The patient recovered, sir. But to what degree, sir, that was not mentioned.
Okay, so this also highlights, even before the COVID times, this also highlights what we have actually blown out of proportion in times of COVID. When there is infection, it generates the same inflammatory cascade which you see in non-infective conditions also. And the final common pathway of inflammation would come in, whether it's autoimmune, immune mediated, or it is infection mediated. And in infections, the role of steroids, including the sepsis and endocarditis, has been underplayed. The neonatologists use steroids in neonatal sepsis with effective results. In adults, it has been propagated sometimes, like in enteric fever, you give 1 dose or 2 doses, and in other sepsis, you can give some. So those kind of steroids to bring down the inflammation, because by the time patient has landed into this multi-organ dysfunction syndrome and there is nothing that can be grown on the blood, implies that bacteria has been taken care of by the body, but the toxins released from the body or the effect of the toxin and or bacteria on the final inflammatory pathway is so huge that anti-inflammatory drugs is what is required, and steroids are used there. So they gave whatever you did based on your analysis, whether it was sepsis or it was immune-mediated inflammation, and both were treated and thankfully improved. Anything more?
No, sir.
Okay, so one more thing. You were saying about the, I think you said heart rate was 132, right? I was actually quite fascinated by that. I should have raised that question of 132 versus respiratory rate of 26. And when I multiplied it, I thought within my mind that it should be a pointer to the respiratory rate versus heart rate should be a pointer to the cardiac involvement. But the question has come from Urvi Arya, why there is no orthopnea and PND since it is a cardiac cause.
Orthopnea and PND, okay. So orthopnea and PND typically reflects a congestive heart failure, which can either be left ventricular or left atrial. Something like MS can also present as orthopnea and PND. And what happens is when there is a rise of left atrial pressure, the left atrial pressure reflects onto pulmonary venous pressure, and then it reflects onto pulmonary capillaries. The pulmonary capillaries get edematous, and whenever the patient lies down, when the patient is supine, basically there is an increase in venous return. So that just overloads the left atrium, and that's what causes orthopnea. PND is also something similar, but PND happens first because PND, it's literally in the name, it's paroxysmal. Orthopnea is whenever the patient goes supine, the patient gets hypoxic or tachypneic. That's why, I mean, it's infective endocarditis with no features of left heart failure. Why would it present with orthopnea and PND? So like, that's my understanding.
So Nilayan, just for me, tell me, how do you separate out orthopnea from metabolic acidosis?
Sir, as in?
Tachypnea of metabolic acidosis versus orthopnea.
So orthopnea typically happens when the patient goes supine from a sitting or a standing position, sir. Tachypnea would be either sitting or standing. I mean,
this patient would not be in a condition to be standing and walking around or running around. He had a respiratory rate of 26. We don't know what it was.
Yes, sir.
Would you say this was part of orthopnea? Or could have been? With a saturation of 94, which you were so much, concentrating on?
So the fact the patient couldn't have sit up, oh, that's a good question. And I didn't think about the patient couldn't sit up, so it could have been orthopnea. So, but okay, so I have no answers to that.
So anybody on that, except that we are saying it could be small or like that. So I think whenever you come across these cases in the clinics, you must keep in mind that tachypnea by itself does not always mean a cardiac or a respiratory problem. Apart from the fever that you have been talking about, a metabolic acidosis would present the same way. The only thing is, when you see a patient with metabolic acidosis, they are not only having a rapid breathing, but they are also having a deep breathing. So you can actually see that they are really making so much of noise in their depth of that rapid breathing that it stands out like more metabolic. But there are times when it can be overlapping. And I agree that a valvular lesion by itself does not necessarily translate into orthopnea because there is a lot of buffer. And a heart rate of 132 actually is good for aortic valve lesions. So for mitral valve lesions, if a tachycardia occurs, then the failure occurs sooner. But in a aortic valve lesion, they tolerate the tachycardia much better. Okay. Anything else better in sitting, orthopnea, and recline and bed? I think that's a very good case. We have taken good amount of time. It is 11:30. What do you have now, Nilayan? Or we ask house?
So I have a second case, sir. I think a few students said the case went over their heads, and I can totally agree. Say it's a little too much at first glance, sir. Maybe I'll run through the first case at the last, just to maybe come up with a homogeneous explanation for everything, so that it gets consolidated. But I will go through that at the last, sir. For now, sir, I will move on to the second case, which is a lot easier. Something more like what we get in exams, a prototypical exam case taken in the typical exam format, sir.
So I think this discussion also actually went a little more deeper because Nilan presented like that. So it was more like, high MBBS level or MD level discussion that set in between. And but that's okay. There is no level when it comes to a case discussion. For me, third semester, eighth semester, and DM, they all stand to learn the same way. Okay, please go ahead. I'll pick up my water bottle. Please go ahead.
Okay, sir. So coming on to the second case, this is a case from 1967. So it doesn't matter though. So I'm going to present a case of 47-year-old female who is a resident of Yamuna Vihar near Delhi. She has a Bachelor's of Art degree and works as a lecturer in DU, and she is married. So she presented to us with a 5-month complaint of swelling of legs and distended abdomen and a progressive dyspnea for 3 months. So the patient was apparently well 10 months back when she had an acute onset illness. It was characterized by nausea and vomiting and a general feeling of unwellness for a couple of days. There were no associated other symptoms. 9 months back, she had another episode of similar illness. About 7 months back, episode of acute illness with nausea, vomiting, and diarrhea with muscle pain, difficulty breathing, and palpitations. She was admitted to hospital and was subsequently discharged after 17 days. 6 months back, so should I stop or
Carry on.
Okay. 6 months back, she developed acute onset of difficulty breathing, severe chest pain that radiated to neck but not the arms, and which increased on coughing and with deep breaths. She was admitted to hospital and adequately managed, discharged after 12 days on digoxin. 5 months back, she was admitted with nausea, vomiting, nervousness, had distended abdomen and bilateral leg swelling, discharged on furosemide. In the preceding 4 months, the patient has been admitted twice with complaints of leg swelling, and so the diuretics were up-titrated. In the last 3 months, the patient has become increasingly short of breath. Earlier, she was able to climb 2 flights of stairs. Now she can only walk from a chair to her bed, which is close by. She also complains of uneasiness while sleeping in supine position and has to sleep upright. For the last 1 month, the patient also complains of a cough with productive white sputum. This is associated with nausea, weakness, and a history of weight gain of about 17 kilograms. There's a history of weight gain. This is also accompanied by a complaint of uneasy feeling in her legs that was neither severe nor localized. Coming on to negative history, there was no history of any Pnd that could be obtained, no history of any recurrent childhood fever associated with joint pain or rash or any abdominal movements, no hoarseness of voice, no palpitations, no loss of consciousness, facial or arm weakness, speech slurring or sudden vision changes, no complaints of yellowish discoloration of eye or body. Coming to past history, the patient recalls an episode of diagnosed phlebitis of right leg of 12 years prior in one of her pregnancies. Since then, she reports having occasional swelling of her right ankle, especially after a long day at work. Patient is not a known case of diabetes, hypertension, or asthma. The patient has never suffered from TB, no history of cardiac interventions or surgery. Coming to personal, family, and socioeconomic history. The patient has a vegetarian diet. She reports having adequate sleep and normal bowel and bladder habits. There is no history of substance abuse, alcohol, smoking, or IV drug abuse. No family history of any similar complaints. She belongs to higher middle socioeconomic status according to modified Toposamy scale. Coming to a menstrual and OBS history, her last menstrual period was about 7 months back. She has had 7 full-term pregnancies. Last one was about 2.5 years back. It was an uneventful gestation. Her parity index reads as private 7, parity 7, life 7, and abortion 0. Drug and allergy history. Apart from digoxin and the furosemide she was prescribed, the patient is not on any medications, including any herbal supplements. No known allergies. So next slide would have my differentials. Should I carry on?
Yeah, please.
Okay. Keeping in mind that the patient had a history of nausea, vomiting, and a general feeling of unwellness, I thought this could be a illness that could have triggered a myocarditis sort of picture. So that was one of my differentials. And the fact that she had a history of phlebitis and the fact that she has occasional swelling of her right leg could indicate a history of DVT. And we know that the DVT can throw clots. So my differentials are such, sir. I would put myopericarditis as first because in one of her earlier episodes, she told that she had a chest pain that increased on coughing. So that indicates a particular pleuritic type of chest pain, sir. So that just sort of made me think of pericarditis. Second would be MI with biventricular heart failure because the features are such, sir. For example, we also have coughing, we also have shortness of breath, we also have something like orthopnea, and then we have leg swelling and leg swelling that is extending till the abdomen and also abdominal distension. So we have features of biventricular failure here. Primary cardiomyopathy with acute decompensation. So I just thought because it is a distinct possibility, sir. And pulmonary hypertension with recurrent pulmonary embolism, sir. Again, sir, we have a history of DVT, which can cause pulmonary hypertension, but this does not explain to us why the patient is having left heart failure. And sir, MS and RHD, this is a premature thought. So going on to examination, she was examined under well-lit conditions in supine position with a peripheral cannula and a bladder catheter in situ and an oxygen mask attached to her. Due verbal consent was taken before the examination. The patient was conscious, alert, and oriented to time, place, and person. She looked ill and was in considerable distress. Vitals were taken. The pulse was 140 beats per minute, irregularly irregular, good volume with no radioradial or radiofemoral delays. Vessel walls were not palpable and all peripheral pulses were present bilateral. BP was measured to be at 110 by 80 millimeters of mercury in the right brachial artery in supine position. The respiratory rate was 16 times per minute. Thoracoabdominal and accessory muscles, the use of accessory muscles were very prominent. The JVP was distended and it was visible till the angle of jaw in upright position, so 90 degrees upright. Giant A waves could be seen, but we could not measure the JVP since whenever the patient was kept at 45-degree recumbency, sir, it went so high that we lost the visualization itself. So we couldn't measure the exact JVP. We just knew it was very, very high. She was slightly febrile at 99.6 degree Fahrenheit. Coming to general physical examination. The patient is obese with height of 144 centimeters, weight of 92 kilograms, and BMI of 44. On examination from head to toe, she was cyanosed on 30% oxygen, which was later up titrated to 50%. She improved. Both her lower limbs were edematous, with edema reaching up till the inguinal region. It was tender to touch bilaterally at the level of thighs, but no redness or local rise of temperature could be appreciated. The skin over both the limbs was grossly normal, with slight pigmentation around the ankle in the right around the right ankle. So sorry for the typo. No pallor or icterus could be appreciated. Her abdomen looked distended. No lymphadenopathy could be appreciated. Coming to systemic examination, sir. First would be cardiovascular system. On inspection, no chest wall defects or spinal deformity was appreciated. No visible pulsations, prominent vein or bulges were present. No scar marks noted. On palpation, the point of maximum cardiac impulse, also called as PMI, was felt 3 cm to the left of mid-clavicular line at 5th intercostal space, which was discordant with the pulse. No heaves or thrills were appreciated. On auscultation, normal S1 at apex was heard. The P2 was heard louder at the pulmonary area than the A2. S2 was widely split, but it was not fixed, and as the splitting increased on inspiration. A grade 2 pansystolic murmur was heard at the cardiac apex. It was low pitched, and it radiated to the left axilla and also along the lower left sternal border. A grade 2/6 early diastolic murmur at the apex was also appreciated. A loud gallop rhythm was also appreciated at the apex. A respiratory examination was grossly normal, sir, except for a bilaterally decreased breath sounds with a bibasal inspiratory crackles that were heard. Also on percussion, dull notes were heard bilaterally in the 5th to 8th intercostal space on the lateral aspect and the 7th to 12th intercostal space on the posterior aspect of chest wall. On the abdominal examination, on inspection, the abdomen was diffusely distended, the flanks were full, the umbilicus was central and everted. All quadrants were moving equal with respiration. The overlying skin was shiny, no scars, signs of fistulas could be appreciated, no distended veins or scratch marks could be appreciated. On palpation, no tenderness or localized rise of temperature could be felt on superficial palpation. Deep palpation could not be carried out as the abdomen was diffusely distended. And on percussion, dull note was appreciated all over the abdomen, starting from the 5th ICS, that is intercostal space on the right side. On auscultation, normal bowel sounds were heard. CNS was all normal. Answer. Thereafter, I have shown 2 investigative findings, that is ECG and X-ray. But should I stop here, sir, and now discuss whatever we have till now?
I think you can continue.
Okay, sir. So an X-ray and an ECG was done, sir, and we can see the ECG something like this. I don't know if it's visible or if it's easy to interpret this, but I will do that. The first finding that we can see is some sort of fibrillation waves going on here in the AVL lead. I think my pointer is not visible. So in the AVL lead, we can see some sort of fibrillation waves. And there is a lack of P wave in any of the leads. So the patient had atrial fibrillation, and the fact that his pulse was irregularly irregular just confirms that. The second finding we can see is a right axis deviation. Okay, how? AVL is negative, AVF is positive, and AVR is positive. We see that AVR is positive. It's obvious that we have a right axis deviation, sir. And then we can calculate the cardiac vectors and then calculate the exact axis. The calculation would come out something to be 120 degrees right axis deviation, sir. So grossly right axis deviation. And so what we can see here, I think those two are the only findings, 2 main findings here.
Okay.
But sir, what the paper reported the ECGs as, sir, like they had more data than these 6 leads, more continuous data, sir. So the ECG was read something like this: atrial fibrillation with right axis deviation, sir. Tall R wave seen in V1, suggestive of right ventricular hypertrophy, which is clearly not visible here, sir. It's almost a flat line sort of picture here. Multiple premature ventricular contractions. By multiple, I mean there was a normal beat, then a PVC, a normal beat and a PVC. So this is called a bigeminy rhythm. This is the X-ray obtained. On X-ray, we can clearly visualize the trachea as in midline, but since the vertebrae are not visible through the cardiac shadow, we can, okay, this is the AP view. First of all, this is an AP view of chest. How we can see that the medial half of the clavicle is obstructing the apex of the lung, and the fact that this faint medial border of scapula is overshadowing our lung fields, and the heart appears to be enlarged. There's a cardiomegaly, an apparent cardiomegaly. So that's how we can see this is an AP view of chest. In this, we see the trachea is in midline. We cannot comment if the X-ray film is rotated or not. For that, we have to compare the medial and the clavicle with respect to the vertebra. But we can see the X-rays incompletely penetrated. And how I say that, that's because we cannot appreciate any of the vertebra through the cardiac shadow. For the X-ray to be adequately penetrated, the vertebra should be visible through the cardiac shadow, which is not in this case. Also, the X-ray that the report showed said that there is an apparent cardiomegaly, sir. But at our level, I think in AP field, we cannot comment if there is a cardiomegaly or not, because there is an apparent cardiomegaly as it is in AP. What other findings we can see is the, okay, the right, I think this is the pleurophrenic angle, sir. The right pleurophrenic angle is not very visible, and this was interpreted as pleural edema, as pleural effusion, sorry, pleural effusion. We can see some sort of reticular shadows on the right lung field and bilateral actually, which is indicative of pulmonary edema, which is also corroborated by the fact that the patient had biobasal inspiratory crackles. And that's it. So what they rated as is AP field chest X-ray, incomplete penetrance, and moderate cardiomegaly. convex left heart border, sir, I could not very well read that, but we can see, sir, that it is supposed to be concave at the left hilum, sir, but it is not so. It is convex, and that indicates some sort of left atrial hypertrophy. However, right ventricular hypertrophy cannot be ruled out. Congested pulmonary vessels and small bilateral pleural effusion, no lung consolidations. So coming on to summary of the case, we have a 47-year-old female with a history of right leg phlebitis and venous insufficiency, presenting to us with orthopnea, productive cough, abdominal distension, and bilateral leg swelling, has a 2/6 pansystolic murmur at apex, or 2/6 early diastolic murmur at apex with an apical diastolic gallop, a 3 centimeter laterally displaced point of maximum cardiac impulse, and a bibasal inspiratory crackles. With this, sir, I can, okay, let me interpret this. A 2/6 so before I give my diagnosis, sir, I would like to explain each of the findings on the cardiac examination, sir. Okay, so coming to palpation, point of maximum cardiac impulse was felt, that is the apical beat, was felt 3 centimeter left of mid-clavicular line. At this point, we know, we can say that the left ventricle is dilated, some sort of dilatation is going on. But then we see it is discordant with pulse, and this now does not make any sense, because the left ventricle, if the left ventricle contracts, then the left ventricle and the pulse has to be concordant. We have to feel them together. The fact that they are discordant points to the fact that this is actually a left atrial enlargement that is enlarged to such an extent that it is now presenting at the cardiac apex. And I think this fact is also mentioned in our practical book, so that's why I highlighted it here, sir. Like, it's not above undergraduate level, sir. This fact was present in our practical book, sir. On auscultation, the S1 was heard at apex and it's normal. That's okay. P2 is heard louder. So usually we hear S1 at the apex or the lower left sternal border, and that is the apex of the heart. And we hear for S2 at the base of heart, that is the aortic and pulmonary areas. At the base of heart, sir, the aortic sound, that is A2, predominates P2 at both the areas, that is pulmonary areas and the aortic areas. The fact that the P2 is heard louder than the A2 at pulmonary area is just indicative of the fact that we have a loud P2 here. A probable cause of loud P2 could be pulmonary arterial hypertension. The S2 was widely split, and that can be explained by the fact by pulmonary arterial hypertension, sir. A2 P2, if the pulmonary arteries are at high pressure, then the right ventricle will take more time to pump the blood against that pressure. So the pulmonary valve will close later and the P2 will be delayed. So S2 was widely split with the splitting increase on inspiration, which is also obvious. Grade 2 pansystolic murmur at cardiac apex, low pitched, radiating to left axilla. So, sir, yes, sir. Okay.
Yeah.
A pansystolic murmur at the cardiac apex usually points to a MR, basically mitral regurgitation murmur. But we cannot rule out an Austin-Flint murmur of aortic regurgitation, that is a regurgitant flow that is hitting the mitral valve, and wait. Oh, I'm so sorry. I mixed up. So sorry. A pansystolic murmur at cardiac apex points to mitral regurgitation. For example, when the ventricles are contracting, sir, then we expect the flow to go through either through the aorta or through the pulmonary trunk. But if the AV valves do not close properly, sir, then the volume of the left ventricle can also escape through the AV valve. And that is what we are seeing, a pansystolic murmur at the cardiac apex that is low pitched and radiating to axilla and the left lower sternal border is typical description of MR. What I was trying to explain was the early diastolic murmur at apex. Now, this can have multiple explanations. One explanation is it's an innocent murmur. That is, if extra flow from the ventricle is going to atria, then extra flow will also be, we will also get extra flow from atria to ventricle and diastole. and that can produce vibrations in the AV valve, and that can produce an innocent murmur, a flow murmur, that is what it's called, or it can be a mild MS, which is causing this early diastolic murmur. A third explanation could be a murmur of AR. AR, the flow of AR, that is when the aortic valve is damaged, then we can have a regurgitant flow from the aorta. And if that hits the mitral valve, because the aortic and the mitral valve are very close together, sir. If it hits the mitral valve, then the mitral valve sort of closes, moves forward, and then we get something called Austin-Flint murmur. That is also a possibility. A loud Gallop rhythm. So this is very interesting. A Gallop rhythm, sir, typically indicates either S3 or a S4. But for a Gallop rhythm, for a S3 or S4, the preliminary requirement, the prerequisite is we have to have a normal AV valve. Because if the flow is not normal, how can we get an S3 or a S4? The fact that we have a Gallop rhythm at apex might rule out MS, because MS essentially indicates that there is an abnormal AV valve on the left side. But a loud Gallop rhythm in this case can also indicate that we have a right-sided S3 and S4. And how is it transmitting to apex? We can recall that the patient had features that were suggestive of pulmonary hypertension. A pulmonary hypertension can cause RVH. If the RVH proceeds, it can also cause right ventricular dilatation, eccentric. Okay, sorry, sir.
I think in a line, it's becoming a little more, academic and theoretical. So maybe wind up, we'll take the views from the participants also and discuss.
Okay. Okay, so I'll move on to the history. So we can start from history.
Yeah. You just you just summarize and complete it, and then we'll throw it over to the others.
Okay, sir. So the history part was very, very typical of a rheumatic heart disease which we get in wards. And why do I say that? Let me try to explain it. Let me go to the history part. 10 months back, acute onset illness. A simple explanation would be everyone gets sick. It's okay. It's normal. 9 months back, a repeat episode. It could indicate a myocarditis-like feature. I agree. But the fact, 7 months prior, she had an episode of acute illness with nausea and vomiting, diarrhea, muscle pain, difficulty breathing, and palpitations. This is a picture which can corroborate the diagnosis of pulmonary embolism. And it is further strengthened by the fact that the patient had a pleuritic type of chest pain, increase on coughing and with deep breaths. This is typical of a pleuritic picture. So the patient had a pulmonary embolism. Why? She had a cause. She had a right leg hepatitis, indicative of DVT. So recurrent PE is a possibility here. And that's how I would like to conclude, sir. So my final diagnosis is this. MR, because we had a murmur with MS, with RVH, that is right ventricular hypertrophy, which is possible due to pulmonary hypertension, caused due to recurrent pulmonary embolism, and MS causing raised pulmonary venous pressure.
Okay, good. Thank you, Nilayan. Let us see if there are some questions coming. Some have been coming. Some more will come. Meanwhile, tell me something. You said this history is quite suggestive of recurrent pulmonary embolism, venous thromboembolism. Now, with this lady presenting every month with nausea, vomiting, and diarrhea, is it suggestive of pulmonary embolism?
Sir, nausea, vomiting, sir, is typical. I agree, sir. Sir, but okay. So the first time she got nausea and vomiting, that is a atypical presentation of pulmonary embolism. I agree. So, but the second time she got nausea, vomiting, sir, the explanation is digoxin toxicity, sir. Because the patient was put on digoxin, the patient is vomiting. There is a chance of digoxin toxicity there, and the fact that she had a bigeminal rhythm and the multiple PVCs, that is very, very suggestive of digoxin toxicity, sir. So that's the explanation for that. But I didn't quote it because I thought it went a little higher up.
No. Wait, hang on. Third time when she came, then also she had nausea, vomiting. Nobody stopped digoxin. Fourth time
Yes, sir,
when
so
she
that is,
came, she again had nausea. Nobody stopped
yes.
digoxin. What is happening?
So the first two incidences, sir, a simple explanation that was given is the patients get sick. So that's the explanation they gave. This is a 7 months back
Hmm.
episode, sir. They said nausea and vomiting is an atypical picture. I very much agree. But palpitations could indicate a pulmonary embolism, sir. However, with these three
Okay.
findings, we cannot rule out a myocarditis, sir. It is very, very much suggestive of myocarditis. I agree, sir.
Okay. You see, when it comes to pulmonary embolism is very difficult to diagnose. And I think the attendance, even though there is 122, but there is no activity on the question or the chat box. So let me just make a couple of comments before we wind it all up. So pulmonary embolism is a very difficult diagnosis clinically. And there have been many studies done because it can lead to acute deaths, it can lead to long-term morbidities. 50% of the time, pulmonary embolism diagnosis is not suspected clinically. So it is so evanescent that the manifestations are just not there. The other thing to keep in mind is pulmonary embolism, when you think that the emboli could go and block a big vessel, which is one-time event this way or that way. Large vessel embolization. Most of them tend to be medium vessel, which come with the clinical presentation that you read in the books or you see in the wards or uh, intensive care units. And the small ones would have a presentation which would be so difficult. They'll keep accumulating those small emboli and eventually would cause some kind of a long-term breathlessness. So the presentation of the small vessel embolization would be very difficult to pick up in the beginning, and it will have a cumulative effect, cumulative damage, long-term damage. Large vessel will not give you time. Medium vessel is most of the time we talk about, which we don't suspect, and it's very crucial that we suspect this. And the hallmarks, of course, would be breathlessness, I agree with you, or with tachypnea and tachycardia. And here, of course, we do the D-dimers and LDH also, as you all know. So pulmonary embolism is very important. One point that you were making and you have answered is, do we say PMI or apex impulse from Pariniti?
It's 12 hours.
Do we say it PMI on clinic on CVS examination or apex impulse?
Sir, I read PMI, but I'm not very sure if it's apical impulse,
Okay,
sir.
both the terms are used. Both the terms are used, and they tend to convey a similar thing. So when you say apex impulse, apex is the outermost and the lowermost palpable part of the cardiac examination when you're doing. Whereas point of maximum impulse not necessarily corresponds with that. It might be a little inside or upside. So both are used. But what is important is when you look at the character of the apex beat, the point of maximum impulse will give you the maximum benefit. And when we were speaking of the examination and you're trying to explain the finding, we didn't actually hear the kind of character of the apex or the point of maximal impulse that was there. Because the character of the beat would give away whether it was a volume overload or a pressure overload or it was like MS. So that is another one you can do. And one thing in the passing, you said the JBP was high up even in sitting position. Is that right?
Yes, sir. Yes, sir.
So when JBP is high up in the sitting position, you don't do it at 45 degrees. You just cannot do it. You know, it's against the laws of physics. So if you're doing like this, you don't want the person to be like this. So actually there is nothing sacrosanct about 45. So it can be 90, it can be 80, it can be 70, it can be 30, or it can even be 20, depending on where you're looking for. So the JPP was very high. And did you say the A wave was very prominent?
Yes, sir, sir. Giant A waves.
So what was the reason for the prominent A wave?
Sir, I thought it was explained by sir atrial fibrillation, sir, because the atria and ventricle are not contracting in synergy, sir. So there is a
No, no,
possibility when
no. Atrial fibrillation, you don't see A waves.
Oh.
Why the history of jaundice was asked? Did you ask for history of jaundice in this case?
sir, I thought if congestive hepatomegaly is a possibility here, sir.
Yes, okay. That was again from Pariniti. But Swati is asking a very valid question. What is the reason of MS in this case? How RHD was ruled out? Rahul also says MS. Why?
Actually, the final diagnosis is of RHD only, sir. It's RHD with MS and MR, with pulmonary arterial hypertension and with recurrent pulmonary embolisms.
So why RHD?
Sir, actually, the diagnosis was okay. So actually, the diagnosis was made on autopsy. So the patient actually died on autopsy. They found the valve had the myocardium had typical Aschoff bodies, and the findings in general, sir, were typical of RHD, sir.
No, you see, that is where the catch is, and that is where we were speaking about pulmonary embolus. So we have these deaths in emergency or in ICUs, and the autopsy is done, and it comes out as pulmonary embolus, whereas nobody ever thought about it. So clinical diagnosis is not pulmonary embolus. Autopsy diagnosis is certainly pulmonary embolism. For our sake, making a diagnosis of rheumatic heart disease would warrant some history of rheumatic fever, complete or incomplete. So that history of rheumatic fever should be there, or it can be or it can be a valvular involvement which statistically favors rheumatic heart disease, like mitral stenosis. Mitral stenosis is rheumatic. And the other ones are so rare, you don't need to consider them, congenital or Libman-Sachs or whatever. So if you have a history suggestive of this rheumatic fever and or mitral stenosis there, but when it is mitral regurgitation, there are dozens of causes. So I think in rheumatic heart disease, you can simply say, you can define your valvular heart diseases first, then you say the etiologic are many, but because of the statistical prevalence, I might think it is likely to be rheumatic, even though there is no history statistic of it. Or because there is mitral stenosis, so I think it is likely to be rheumatic. So you must be clear on that. And this other thing you said was MS, mitral stenosis, but there's no murmur to suggest MS.
Yes, sir. I agree, sir. So, diagnosis of MS, sir, was not made on it was not made on
No,
clinical
autopsy,
examination.
no, even the S1 you said never said was loud.
Sir, that can be explained by the fact, sir, if the valve is calcified, sir.
No, that is okay. You can't have everything in your favor. Your JBP is not going with MS. Your auscultatory findings are not going with MS. Your wide split is not going with MS. You have no opening snap, and you have nothing to suggest actually MS. Tell me something. The primary thing that you had was a pansystolic murmur. So I think for the sake of completing our case, what are the causes for pansystolic murmur? Apart from MR. So
Should
somebody
I?
has already answered, Rahul. Yeah, please, you can tell. Rahul has said the second one, that is VSD. And the third would be MRTR VSD, Swati Yadav. Good, chronic. And the question is coming, what was his 10-year back history? Did you say something 10-year back history? Rahul is asking.
Oh, no, sir. I just said that we could not get any history that was suggestive of a rheumatic fever.
You could not get any history of rheumatic fever. So that is one more. And I think it's a good case because so how does pulmonary embolism come in?
Sir, okay, sir. So the fact that sir, she had a pleuritic type of chest pain in one of her episodes, sir, and the fact that she had a history of phlebitis, she had a history of venous insufficiency, sir, which I mentioned over here. since she reports having occasional swelling of her right leg. This is typical of venous insufficiency, sir. The fact that her ankles were pigmented, sir, that is also typical of venous insufficiency. And sir, I also mentioned in my GPE, sir, that it was tender to touch bilaterally at the level of thighs. So this was taken to be as a case of active inflammation, active venous inflammation, sir. So they thought that this could be a case of recurrent pulmonary embolisms because of these three findings: the fact that she had a pleuritic chest pain, the fact that she has a very good risk factors. So she has had 7 pregnancies. She had phlebitis, so that's how they said that it's pulmonary embolism.
I think thrombophlebitis and deep venous thrombosis are different entities, and thrombophlebitis actually is more common, and especially in this scenario, and in women, it's even more common. But that does not translate. You see, the reason why I'm asking or saying this is that you are making 2 different diagnoses. One set is valvular heart disease, and second is pulmonary embolism. Both are very important. Both will need treatment also. But usually we try to make one wholesome consolidated clinical diagnosis in one patient, though the second can occur. But we make second only if something cannot be explained by one unified diagnosis. So that I think you'll have to keep in mind before you coming to the second one. And what else? There was some other murmur you had apart from pansystolic murmur, early diastolic murmur. What was early diastolic murmur? Was it AR or PR? Hello, I think we are losing everybody. We are losing. It's break time. So can cause AR or PR. Pariniti has already, okay, she is writing AR or PR can cause early diastolic murmur. And you must remember that these are difficult murmurs to be picked up. And once you pick up, it's very difficult to separate the 2 out. Even if you want to see the change with inspiration in the 2, then it can be difficult to appreciate. But there is one easy way of differentiating between the AR and PR, apart from the context as to what the other diagnosis suggests whether this person is likely to have AR or PR. PR usually is secondary to secondary pulmonary arterial hypertension. So one easier way would be to look for the peripheral signs of aortic regurgitation. They are easier to see and they are always accompanied when there is AR. Okay, so I think PR due to pulmonary hypertension causing damage to pulmonary valve. Not damage, they just dilate it. So, okay, that's good, Swati. So I think you have something more in the line, otherwise we'll conclude, I think. Because I can see, to have the, to have everybody's concentration continuously for such a long time is not easy. And
Yes,
we
sir.
just keep doing it because we fill up all the time is not right. You have done a wonderful job. You have taken difficult cases, you have analyzed them very well, and you have also gone into the basics and the cohesiveness of a clinical case. And it's good that you have taken such an active participation. And I would suggest that we should have not one, maybe we should have 6 persons, six students participating in these clinical case discussions. So we can end. Rahul says dancing, 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 dancing pulse, dancing carotid pulse. Okay, so what Nilayan started with was think with an open mind. Very important, very important. Think with an open mind, especially when you come to the exam. Some JR, PG, SR gives you the diagnosis and your mind shuts. Your mind starts working on fitting all your findings to the diagnosis that has been given to you, or your mind starts fitting the findings into the diagnosis. So it's very difficult. Like take the classical example, the first case. If you diagnose it as sepsis, bacterial sepsis with multi-organ dysfunction, with hepatic involvement, muscle involvement, and DIC and whatever, you'll get full marks. But if the diagnosis comes out as, oh, it's aortic incompetence or aortic AS with AR and endocarditis, and the rest is all secondary, the sepsis, then everybody thinks, how did you come to AS-AR? Or in the second case, you came with MS. How did you come to MS? It tends to suggest that you have some other reason for arriving at the diagnosis. And that is not going with an open mind. Open mind is your mind is absolutely clean. You are not biased. So I think what is said with, I'll ask you to remember, think with an open mind. And I will add to that, think with an open mind and analyze with a scientific mind. And you would always be successful in your life. Thank you so much for attending today's class. You can always give us feedback and we'll see you soon sometime. Meanwhile, have a nice day. Enjoy yourself. Take care. Stay safe. Stay healthy.
Thank you, sir.
Okay? Right. Bye. Oh, how do I stop sharing?